Or maybe we'll kick off. So it's quality rather than quantity for the audience. So it's a great pleasure to ask Paddy O'Dwyer to come back. As you know, Paddy did one of the original Watchful waiting trials. We feel it's perhaps been misquoted to fit into people's ideas. So let's hear from Paddy. What does he think? Has his trial been misrepresented?
I think it would be a bit unfair for me just to discuss my own trials, since there are two randomized clinical trials in this area, one from North America, Bob Fitzgibbon's group, and one from our own group. This, I think, kicked off because of a paper we wrote about 20 years ago where we looked at 1,000 patients and symptoms from hernias in 1,000 patients. And we found that almost a third had no pain. And about 10% of the patients that came to us had their hernia for 10 years or longer. So we asked the question, should we be repairing these people's hernias? It was clear that people could tolerate having a hernia for a long, long time. And maybe not everybody needed a repair. And we knew that from general practitioner data and that out there, that people, not everybody was having a repair. But we didn't know what the denominator is, whether it was half of all hernias, whether it was 20% of all hernias. We just didn't know. So there are two randomized clinical trials. This is our one published in the Annals of Surgery in August 2006. And this is Bob Fitzgibbon's one reported a few months later. So both trials started pretty much at the same time. And I'm sure they were driven by our original study of 1,000. Certainly our one was, and I suspect Bob's was also. So one of the things, of course, that's important in hernia repair is chronic pain. And if you've got a painless hernia, the last thing you want is somebody to end up with a painful groin problem. And our chronic pain is defined as pain persisting for a year or longer. So that was our primary endpoint, pain at 1 year. The Fitzgibbon study was pain and discomfort at 2 years. And we used pretty standard methods of assessing pain. Visual analog pain scores, the short form 36, and Bob Fitzgibbon also used a composite pain score. So in essence, what both studies set out to find out is that if we did indeed repair painless hernias, did we cause pain? Did we cause chronic pain? And again, this is a pretty standard thing that this is our trial profile from that study. And as you can see, most patients went on to be randomized, and at 1 year, the vast majority of patients were seen at follow-up. Bob Fitzgibbon's study was a much larger study, a lot more patients screened, a lot more patients excluded, and just over 700 randomized. And again, at follow-up, you can see that they've lost quite a lot of their patients. Over 11% of their patients are lost at follow-up. And this compares very differently with ours. The other thing that we did in our study that was unique, ours is kind of more of an explanatory trial, and theirs is very much a pragmatic trial. We went to the local GPs and asked the GPs to make sure they referred all the hernias that came through their practice. Whether they did or not, we'll never know, but we did that before the study to try and get a good feel for the denominator. One of the big differences in our studies, of course, was that the American study and the diagnosis of an inguinal hernia seems to be a real issue here. In all our patients had a visible lump on standing, and it's very rare for me to make a decision on the basis of a cough impulse, to say this patient has got a hernia on the basis of a cough impulse. But as you can see, half of the hernias entered into their study, or so-called hernias, were made in a diagnosis of a cough impulse. And this may give us some idea as to why rates of hernia repair are so high in the United States. They're about twice as high in the United States, rates of inguinal hernia repair, than they are in the United Kingdom. And this may be the factor, is that a lot of patients have a hernia diagnosed in a cough impulse, which is very imprecise. So the long and the short of it is that there was no difference in chronic pain between our patients when we looked at pain scores at a year And when we looked at outcomes, in fact, our patients that had an operation, their quality of life was improved a little bit. But the significant thing was that there was no difference in chronic pain at 1 year between those that had an operation and those that were just observed. And so we came to what I think is quite a reasonable conclusion. Does not affect the rate of chronic pain and may be beneficial to patients in improving overall health and reducing potentially serious morbidity. Now, Bob Fitzgibbon's conclusion was very different, and this is what threw the cat among the pigeons. So how he could make this conclusion on the basis of his data? His data was exactly the same as ours in terms of no difference in pain between the groups. But how you can say watchful waiting is an acceptable option for men with minimally symptomatic inguinal hernias, delaying surgical repair until symptoms increase is safe because acute incarcerations occur rarely. How can you say that on the basis of 700 patients followed for 2 years? And this is the conclusion that everybody subsequently used. And I guess it's because it's an American publication, people I don't quite understand why, but you know, that doesn't, your primary aim and your conclusion should answer your primary aim, and their primary aim is the same as us. Does it increase chronic pain? And the answer in both studies is no. And yet they come up with this conclusion. For me, it beggars belief, but that's their conclusion. And I'm surprised that it got published, that was allowed to be published in JAMA, that conclusion. So what we both noticed, and this is our study, so at 26 months, at 15 months, 26% of our patients had converted to operation. And the reasons for conversion were pain and rapid increase in size in the hernia. Some patients rather got dramatic increases in size in their hernias in a relatively short period of time. So at 15 months, already 26% had crossed over to the operation arm. Bob Fitzgibbon noticed the same in his trial, but as you can see, the crossover is not quite as high. And again, this may be related, and it's almost certainly related to the fact that, in my view, up to 50% of the patients didn't have a hernia in their study. That's a bit cruel, but I think it's true. So we certainly had always intended in following our patients long term. And so we followed our patients out for 7 years, brought them all back and re-examined them to see how many had underwent operation and how many had developed a hernia, had become symptomatic. And Bob Fitzgibbon did the same and published 2 years later on their data. So this is our data. So 70% of our patients had converted to operation at 7 years. So we were seeing a kind of 20% in the first year or so, and then something like 10% per year thereafter was converting to operation. And this went along with what our original study suggested, that people could tolerate a hernia for a long time before they would present for repair. And you can understand that with people who have got busy jobs and minor symptoms from their hernia, we wait for sometimes an operation until they're retired, or indeed until it's a suitable time for them to have their operation. So our conclusion, again, I think reasonable, that most patients with a painless inguinal hernia develop symptoms over time, and surgical repair is recommended for medically fit patients with a painless hernia. Bob Fitzgibbon study, same thing. So it's good to see actually both studies, but again, you can see that their conversion rate at 10 years is still lower than ours. And again, this harks back to the fact, in my view, that some of the patients in their study really didn't have what we call a true hernia, true inguinal hernia. But nevertheless, both studies, which is, I guess, rather rewarding, show the same thing. And their conclusion, again, they're a little slow on drawing a conclusion. Should be counseled that although watchful waiting is a reasonable and safe strategy, symptoms will likely progress and an operation will be needed eventually, instead of saying we should recommend operation for these patients, which is, in my view, the correct conclusion. So have our trials been misinterpreted? The answer to that is yes. And are we partially at fault? I think our conclusions were very reasonable. I don't think Bob's were. Thank you.
Any questions for Professor Dwyer? Yes?
No strangulations in either study. We had 2 of the 80 patients that came in acutely, and they had a kind of a similar figure.
Martin?
Yeah, I think that there's undoubtedly that case, and that's why we need to really look at our outcomes and have good data and be able to sit down at these meetings and say, come on, this is nonsense. These people need to be looked after. We need to do appropriate operations and improve these people's quality of life.
I think David will deal with some of that in the next talk. Any other questions? Yes? Yeah, well, David thinks he'll answer that in the next talk. Yes? Is that because you're not sure or the GP's not sure? Okay. So primary care, organised ultrasound, shows a hernia, comes up. What do you think, Paddy?
I think if they're asymptomatic, most often, in my experience, these people are looking at a lipoma of the cord rather than a true hernia. And most of our, unless you've got an ultrasonographer in your area that's really interested in looking for hernias and does a valsalva and all the various things that he should do, but most of them are just looking at a lipoma, and they diagnose that lipoma as a hernia, which in actual fact it's a lipoma. Yeah, if I end up operating, then I would remove it, yes. Sorry? Again, in young patients, if it's a young man, no. But in somebody older, then I would. But again, reluctant to put in mesh into somebody who has got a normal posterior wall and an intact inguinal canal. I'm reluctant to put a mesh in, somebody in their 20s or 30s and have a lipoma of the cord that just excites the lipoma and leave it. Because it tends to taper off at the as you know, at the internal ring.
Thanks, Paddy. Just before you go, just to summarise that. So as one of the modern-day fathers of hernia surgery, you are now suggesting that if a patient has an obvious bulge, but doesn't have much in the way of symptoms, that you are probably encouraging them to have an operation, as opposed to saying go away and come back when it bothers you.
Yes, that would be my practice, to encourage an operation.
Okay, thank you very much. It's a pleasure to introduce next speaker is David Sanders. Now, some of his thunder's already been taken in the discussion, but David's going to talk a little bit about the recent hernia commissioning that was done in England. It was done partly by the British Hernia Society with some other organisations, but that's not entirely true. The commissioning document was really all the work of David, not because we're blaming him, but he's actually the person who does all the work. So, David, talk to us about the commissioning guidelines.
Thanks very much, and once again, it's a pleasure to be here. I've got the task of talking about commissioning and hernia surgery, and hopefully I can answer some of the questions that have been raised following the previous presentation. And in the recent times, we've seen articles in newspapers such as the Daily Mail, such as this, and you might be thinking, well, the Daily Mail is not really the pinnacle of medical reporting, and not only medical reporting, but really all reporting. But perhaps slightly more worrying, as this came from, during the last year, this came from John Appleby, the chief economist from the King's Fund. He put this on Twitter. It was based on PROMs data and questioned whether inguinal hernia surgery was a cost-effective treatment, and very much put up the argument against. And these are the sort of documents taken directly from commissioning bodies currently within the UK. So requirements for surgical treatments, a history of incarceration or real difficulty reducing the hernia, a hernia that's increasing in size month on month, affecting the activity of daily living, inguinal scrotal hernia, strangulated hernias and recurrences. This one's from the Birmingham Solihull CCG, incarcerated hernia, symptomatic hernia, strangulated hernia, in brackets emergency surgery, and then at the bottom there's nicely stated in keeping with the European Hernia Society guidelines, which I can tell you for a fact is completely not in keeping with the European Hernia Society guidelines, and more of the same. So where is this really coming from? And I'm afraid to say that we've just heard where. And this is political spin on papers that were published, both Professor O'Dwyer's paper and the Fitzgibbon study. And we just heard lots about this and the conclusions that came out of the two studies, and I won't go into a lot of detail on their initial studies. The follow-up studies were very interesting, performed in 2011 and 13 respectively. And this table sort of just breaks them down to make it a little bit easier to digest. So the Fitzgibbon study, asymptomatic or minimally symptomatic inguinal hernia in adult men, 720 patients, split into Watchful waiting and Liechtenstein repair, 364 and 356 in each group respectively. At the initial follow-up at 2 years, 23% had crossed over to surgery from the Watchful waiting group. When they did their follow-up study at 11.5 years, 68% had crossed over to surgery, and they said that their risk factor for crossover was age greater than 65. O'Dwyer study, adult men greater than 55 years, slightly younger age group, 160 patients, 80 in each group. Crossover at 1 year, 16%. Crossover at 7.5 years, 72%. So not hugely different, but a lot of patients there crossing over to the surgical group. And they concluded that asymptomatic or minimally symptomatic inguinal hernias in men will likely become painful. The risk of an acute event is unlikely. And therefore it's safe to watch and wait, but surgical repair should be offered to all medically fit patients with a groin hernia. But this has been misinterpreted. This was a commissioning guide that we published in 2013. The next edition of this is coming out in 2016, this year. And we made a grave mistake, a naive mistake in this commissioning guide. And I'll talk you through two areas that were referred to. One is whom to refer, and that was one of the questions. The commissioning guide for all the CCGs clearly states that all patients should be referred to secondary care, with the exception of ASA 4 patients who have asymptomatic hernias and have already been discussed at GP level whether they want to repair or not, and they don't want surgery. So this is a demented patient who's in a wheelchair who has an asymptomatic hernia, and there's not much point in sending them up to secondary care, but everyone else should be referred. And the referral guidelines were very much based on who you should be referring to, as in if it's a recurrence, you should try and refer back to the same person who did the initial procedure, but you should refer to someone who can perform laparoscopic surgery if it's recurrence, similarly for bilateral hernias. The second section, who requires an operation, and there was a lot of evidence put in behind this, but it didn't make it into the main commissioning document. It was all additional data. And it's the second line down where we have a problem, because we quoted the papers and the best evidence factually, not thinking about the political spin that might be put on this when it comes to cost savings. And we said that patients with asymptomatic hernias can be managed conservatively, and that's probably the wrong word to use, but there is a likelihood of requiring surgery in the future. So I think we have to ask ourselves the question, and this is a question that I put back to John Appleby, what would be the effect of not routinely repairing inguinal hernias in the NHS? And what we have to do is we have to look at countries that don't have a routine elective hernia service. Sub-Saharan Africa, parts of South America, Moldova in Europe. And if we compare Ghanaian hernias compared to UK hernias from the publication that came out, looking at that, 64% of Ghanaian hernias extend into the scrotum compared to 77% of UK hernias. 72% reduce quality of life so that people can't work, compared to only 2% of hernias in the UK. And this worrying study from Nigeria showed that 20% of patients that were coming in for emergency hernia surgery died. Now, clearly that's multifactorial, but not having an elective service plays a big part. And in the Global Burden of Disease report, which was published last year, they said that an elective hernia service is one of the most cost-effective measures that any healthcare service can have. Comparable or better in terms of cost than insecticide-treated mosquito nets for malaria, antiretroviral therapy for HIV, and oral rehydration salts for diarrhea. And they said that any developed healthcare service should, as a principle, have an elective hernia service. That's straight out of the Global Burden of Disease report from the World Health Organization. So what's the effect been of rationing the care of hernia surgery? There's two studies, both relatively low quality studies that have come out. This one was published in the Annals in 2014. It looked at 1,032 patients versus 982 patients 16 months before and after the change in CCG policy. And the results are quite alarming. 59% higher odds ratio of emergency repair. Higher odds of adverse events, 4.7% versus 18.5%. Mortality of 0.1% versus 5.4%. The second paper, looking at the change in policy in the Bristol area, 857 versus 606 patients 12 months before and after the commissioning policy change by their CCG. Emergency repairs, 98 versus 150. 30-day readmission, 5.1% versus 8.5%. Alarmingly, the bowel resection rate, 0.97% versus 12.9%. And the length of stay, 24 hours versus 3 days. I don't need to go any further. There's no debate. Restrictive criteria clearly produce worse outcomes. They're produced by commissioning bodies that don't understand the natural history of hernias. They're draconian requirements. And we have to be very clear about what sort of NHS service is provided. Is it a service that's the best possible care, that's free at the point of access, or is it a ration service that provides emergency surgery only? Thank you.
So a fairly bold statement from some low-level evidence. Questions? Yes?
Well, I think it needs to be addressed in the next edition of the commissioning guidance that comes out. Again, it's just guidance. The commissioners don't have to follow it. But all the evidence points against to rationing hernia surgery. So I think that's the first step. And then see how the commissioners, move forward from there. It depends very much on what happens with regard to the NHS and the sort of service that the NHS wants to provide. Yes. Yeah. So, yeah, it has. I don't have the number of hernia repairs. 15% of CCGs have determined Groin hernia repair in men as a procedure of limited clinical effectiveness. That's 8 CCGs in the country. Small number at the moment, yeah.
Any other questions? Well, that was a fairly clear, I think, idea of what the commissioning group have to do to get it right. It's a bit down to legal statements. It's the devil's in the wording, and then the interpretation of the wording. And I think also, David, before you go, the impression was that these people should be referred, and any decision about surgery, not surgery, should be with a surgeon who undertakes hernia surgery.
Yeah, absolutely.
Not delegated to primary care.
Absolutely. It's a very personal decision that needs to be made at the level of secondary care with the surgeon who's going to be performing ideally the operation.
Thank you. So moving on away from the local scene, we do have two international guests with us. So Thue from Denmark, I think, is going to kick off and tell us what are they doing in Denmark to improve the lot of patients with inguinal hernias. I hope you're doing something.
Okay, thank you for this kind invitation, Andrew. I'm much honored again. I showed this picture last session. It's just to stress that this database from Denmark started with the groin hernias in 20 years ago almost. And I will try to present some of the most important results from this database. But again, I was challenged by Andrew to say something about what not to do. And this is actually a repetition of what I said just 1 hour ago. So I will not go through it. But what we started was to put up 1 or 2 hypotheses just to build up this database. We didn't want to solve the problems of the whole world, just 1 or 2 hypotheses. And then again, a few variables and stuff like that. And what we came up with was the impression that we had far too many recurrences. And that was the basis of starting the database. We had far too many. And why did we have it? And what could we do about it? So we thought, and I know it's as a non-word saying, we didn't want this tailored approach thing. We wanted a standardized thing. All this about tailored approach in our mind is that everyone can do what everyone wants to do. And I don't think that's the way to do, although biology is biology. I'm sorry, Sanders, but I don't like that tailored approach thing. So that was part of the plan and the hypothesis. So we went to the first 3-4 years of the start of the database. We looked at on the first 30,000 patients, consecutive patients, based on our discussions, and that was more than twice a year. We met a lot of time with all the surgeons in Denmark, and I told you about this slide. What it's all about is to have these good discussions, a lot of beers, a lot of fun, and a lot of scientific things, and a lot of work. And so we managed by this discussion and this discussion and attention, we managed to, and I know the Schuldeis Clinic will hate us, and they do hate us for it. We sort of minimized the use of sutured repairs and maximized the mesh repairs over the first 30,000 patients, and over the years we promoted the laparoscopic repair as well. I'm not going further into that part, but the beauty of this was that you could show that as we increased the use of Liechtenstein repair, we decreased the rate of reoperation for recurrence. And the sutured repair, they just kept on having a repair. And we can show that even after many years, that it's the Liechtenstein. If you avoided a repair, a Liechtenstein recurrence within the first months, then you would not have one. reoperation. But if you had a suture repair, you could just go on, and you will have your problem finally. By governmental rules, we are obliged to report some kind of standard. And we have one problem, actually. I don't know whether it is a problem, but we should be below 1%, as Saunders said, below 1% for recurrent operations. But we are actually now in Denmark in 2014, 2%. And I know why we are that, because we have some centers doing too few of these procedures, and that's a problem. And we write them, and they're very angry at me, and it's not good. But still low numbers. And we have introduced new standards. We have an obligatory nerve identification. I don't know whether that would help for chronic pain or not. And we want more than 80% to be operated laparoscopically if you are a female, due to the higher risk of having a femoral hernia. And also we want a supervised training for more than 40% of these procedures. So what about being a young guy, 17 years old, 16 years old, fully grown up? Should you have a repair suture? Should it be Liechtenstein? Well, we have data on that, quite some thousand patients, and this was the guy having a conventional no-mesh repair. They did much worse. They had more recurrences than the Liechtenstein repair. But should you then recommend a Liechtenstein for young guys, 18 years old? Should they really have this mesh inserted, or shouldn't they? I mean, you are in low numbers, 4% versus 2%. So should they have a Liechtenstein? What about chronic pain? Is young age a risk factor for chronic pain? Yes, it is. There's a lot of well-known, well-described risk factors for chronic pain. That is young age, actually, female gender, and how you are pre-operatively. Are you a vulnerable person? Do you have chronic pain syndrome and stuff like that? So the question is, Liechtenstein or sutured in young adults? That's not a question to pose, in my opinion. And this is a level, evidence level MNOP or something. But I think the right question is, the right thing is laparoscopic repair with glue fixation, or at least a non-traumatic fixation should be done in young people, simply. And when are you young? In my department, you're young when you are below 65 years old. Just because that's the median age in these patients in my department. So that's what I promote. Another milestone, not because it's from our country, but it's how should you repair the recurrent hernia? If you have a Liechtenstein, what should you do then? Should you have a Liechtenstein, or should you have a laparoscopic? And the answer is quite easy, and it has been demonstrated several times, although not in a randomized trial. The first open, then the next should be laparoscopic based on 70,000 patients. And if the first is lap, then the next should be open. I'm not saying that you cannot do lap, but it's just more challenging. You can do it. It's not that difficult, but just for the general advice, this is the rule to remember. Now, this is completely out of line. It's just because I like this study. It's about mesh, and it's Uganda, Swedish study. You may have read it. It just came out in the New England Journal. It's an elegant study. They randomized patients to mosquito versus commercial mesh, and that is randomized patients to $1 versus $100. And what did they find? It was not a non-inferiority randomized trial. It was just a randomized trials with 98% follow-up. Well, outcome was completely the same. So it's a very, very important study for the third countries. So you can just take your mosquito, boil it, and put it in local anesthesia. Yeah. So in conclusion, Mesh repair, yeah, it's a standard, but in some patients you should not do it. You should not do it in the young ones, in my opinion. But I may be wrong, Saunders, I may be wrong. But I would not have well, I'm not young anymore, but I think the lab should, in many ways, be the standard procedure, also in respect of risk of chronic pain. Lab repair, yeah, standard, but not in all patients. We have a little problem in Denmark. Recurrence rates are increasing, maybe due to bad education. Now we are benchmarking, we're educating, we have increased intention in the database, and I hope we will go down again. And I don't want to see that again. Thank you for the word.
Thanks very much. Any questions from the audience? Clearly you've been driving laparoscopic repair, and now you're telling us from your registry that recurrence rates are going up. Is that because the non-specialist or the non-expert laparoscopic hernia surgeon is now having a go because you've told them to have a go?
That the number covered open and lap. It was not divided into lap, only lap. But in the early period, when lap was introduced, we had specific problems with the bilateral lap procedures, and that was mainly due to two departments. And one private guy thought he was good at it, and he wasn't. And now we have followed again the lab procedures over the years. It was perfect, 2%, 1%, but now it's up. The lab recurrence rate has an increasing tendency. So then we have to go over again. It's a continuing challenge. In Denmark, by tradition, we almost only do tap, not the tap. I missed your question, sorry. From the TAP procedure, you mean? Yeah, we have had in our national journal of surgery, we have had 2 cases reported. That's not the truth, but that was one patient had a bilat lap where the suturing was with this V-lock suture, and the V-lock suture on both ends, they entrapped, they met each other, and that was, then they had a bowel obstruction, and then there was another one with the glue fixation slipped, and then he had a bowel obstruction, and we have had, I've also seen bladder lesions, and we're very rare, and I'm in the authority of the legal something I can't in English, but I've had one guy having two perforations of the aorta doing this TAP procedure, and now he's not a doctor anymore.
Can I just ask you something very, very quickly, just something that you made reference to during the talk. So your sort of standard procedure is a laparoscopic repair, a TAP. But as people get older, over 65, you do an open repair, possibly. And if someone's had a previous lap repair, you do an open repair for the recurrence.
No. Then we follow the strict, the easy
the
rule.
The opposite.
Yeah.
So you
you talk the first question. You talk about a primary hernia.
Yeah. So you do tailor your surgery.
Got you.
Any other questions from the floor? Yep.
If I understand your question correct, you have a patient who has not been operated before. He comes to you with pain, and you feel nothing. You have an ultrasound, and you see something. Is that the question?
Yeah, so the patients with chronic pain,
Uh-huh.
usually come to the clinics having an ultrasound scan saying they have a small hernia,
Yeah.
which nobody can feel.
Which you can't feel. Well, I would be reluctant to do a diagnostic laparoscopy, but sometimes you're forced to do that, and then you can take down the peritoneum and see if it should be a femoral hernia, and then suture it again. But I tend to trust my hands instead of ultrasound. I personally I do not like MRs, scans and ultrasounds and stuff like that for this kind of.
So talk us through what you would do with someone who has pain in their groin, possibly an ultrasound suggesting something. On clinical examination, you don't think they have a hernia. What do you do? Do
Yeah.
you send them away?
No, then you have an intuition.
Yeah.
A clinical. I must admit, quite often I offer them in the same day surgery clinic a diagnostic laparoscopy, and I don't do the TAP, so it's very easy with the TAP, and mostly men do not have a femoral hernia, which you can't see, but it's not that seldom. And in the literature, actually 12% of females that when you take down the peritoneum, they actually do have a hernia, a femoral hernia, which you can't see.
Martin?
I have a final question for you, Thue. One of the concerns that we have is identifying the underperforming surgeon, someone who not should be stopped, but should be helped in their training to improve. From the registry, do you get any feel as to how many operations you need to audit for a surgeon before you can say they are sufficiently underperforming that you want to change their practice? Is it 10, 50, 100? Feel for the number of operations that identify whether you're underperforming?
Well, the Swedish did publish on that in the annals, sorry. And we don't have that because we only have numbers per institution registered now. It's just now we are benchmarking individualized surgeons. And if the institution performed less than 50 operations per year, they did worse. And that doesn't, I don't know how many surgeons it was, but we know from the Swedish Register Annals Surgery study that if you do less than 5 a year, and what is that? Stupid, less than 5, then you should not do this. And that's very clear. And then comes, what about if you do 5 to 10 or 5 to 20? Well, it's less clear, but the tendency is, if you bike a lot on your bicycle, then you're doing better. If you have a New York guy coming to Copenhagen renting a bike, he's lousy. This is not big science.
So the feeling would be stop low volume, very low volume, and the impact of that would be very small. There aren't too many low volume centres. If you add 5 to several thousand surgeons, it's not a big.
Except that's from his data, so it's not picking up. It's not picking up any private practice. His is unreliable, and I don't know where the numbers come from saying that the 25 should be the cutoff. There's no evidence for that. Yeah, yeah.
It's just, this is so easy. What would you have yourself? Would you have a guy operating 5 procedures a year, making yourself a chronic pain patient? Never, never.
Well, something to, yeah, question? I think that's very true, and I would say, you know, without being unkind, I think you're a similar vintage to me. And one of the questions that was posed by Paul and his team was, what happens if you have done lots of hernias in the past, but because of change in your practice, only now do a few, as opposed to a new generation of surgeon who comes along who may have done 30 in their training and is now only doing 5 or 10 a year. Are they ever actually going to be trained? And that is a separate question as well to those of us who really learned to operate on inguinal hernias and did lots of them. Maybe badly, but we hopefully got better with time. One last question.
I have no clear answer for that, but it's just I work in Copenhagen. I'm the single referral center for patients with chronic pain after lap and Liechtenstein, and I'm very well aware that I'm biased, but I've seen so much terrible surgery in young guys having lipomas removed by surgeons obviously not knowing what they were doing, and terrible descriptions of anatomies, but I'm very biased. So again, evidence level X. So.
Okay. Thanks very much. Moving to our second international speaker, I'd like to welcome Ralph back to the podium to tell us what Germany are up to improve the lot of patients with inguinal hernias. Ralph.
Thank you very much for this introduction. And of course, we have in Germany a totally different concept. We are not working really on a guideline like in Denmark. And please apologize for these 2 comments. It's not even that simple as we have seen right now. I think one fact is that not every open procedure is a Liechtenstein procedure. What do you do in that case is where you make a pre-pivotal placement of a mesh? What do you do afterwards? And the comment for the recurrences is quite different because have you proved in your first surgery when you do a Liechtenstein repair, is there any femoral gap or not in female patients? I think so. I think there are a lot of open questions, and I think we are not on the end of the discussion, what's the best in what case. So we are focusing much more on a tailored concept. What is doing Germany instead of that? We have, of course, this database, which is developing since 2009. We have made some publications. I don't want to focus on this issue because the coverage in the country is not 100% like in Denmark or Sweden. We have a different strategy which is focusing much more on our education program. So I would like to present the education program in Germany because we think that the surgeon has the biggest impact of the outcome. And so we have no conflicts of interest, and I would like to present our strategy to improve the knowledge of the surgeons in Germany. There is a collaboration with the German Surgical Society. They support us with this strategy, and the idea was firstly in 2010 to establish a systematic overview for hernia surgery, a practical orientation, and to improve finally the part of young surgeons into our conferences. There is a combination, and we call this Hernia Total, which is the compact course, which is combined with a study meeting of the German hernia database, and finally a conference which is more practical orientated in 1 week. That's once in a year. The preparation starts in 2010. The first basic course was held in 2011. We have the patronage of different surgical societies, and we have, of course, the credits, and we have made the survey, which I have introduced already, and we created a combination of different parts with a hernia school. The realization starts right now, and we have additional different platforms, a video platform, an e-learning platform established right now. This slide you have seen already. I think, of course, there is a sense to improve such education systems, and the training, step-by-step training, seems to make sense. That's something which is summarized also in different papers. The realization looks in this at this stage in 3 parts. The compact course as a basic, the concrete as a, I think, continuing more detailed course, and the complex as a, I think, advanced surgeons component. The target group of the basic course is not even only the residents. I think we focus also on all the surgeons who want to get a fundamental update on hernia surgery, because in the last 20 years there was a lot of change, and of course to bring them once again back on what's going on. These are the courses which are held in different big cities of Germany, and also since 2014 in Austria. And I can announce already now that we are preparing something for the European Hernia Society meeting in Vienna, which will be not in a German-speaking manner. So instead, we will do it in English in an international platform. Firstly, we would like to get an insight what are the needs for the residents and the surgeons who will join this course. The survey is on experience, and we get much more information about the surgeons and their practice. And of course, you are absolutely right that the knowledge of the surgeons, it is very different. The compact course as a basic course include, and that's, I think, in my personal opinion, also the most important thing is the anatomy. Once again, go back into the anatomy. It's, of course, excellent, and also for an advanced surgeons, you learn much more. We put into this whole day of anatomy lectures, not only lectures, demonstrations. We do a simulation-based training, an ultrasound course, which is very simple and easy to do if you do it. And finally, in the afternoon, a cadaver operations. And the second day is hands-on training in different training centers, and you need, so that you have small groups of 3 to 5 per OR table, you need a lot of course, hernia centers. They will be elected locally, and they must have a huge amount of hernia procedures per year. And of course, they must look into their data. One fact is that they must participate in the hernia database in Germany. On the third day, and we invite also international speakers for theory and the Congress Center. We had put an image film since 2014 for, I think, to reach all the new residents. Also, we have added a script for every participant, which is like a book. This booklet is a script which includes not only all the techniques within, of course, like a cookbook to follow. Also, diagnostics are involved in this. So I think we do a lot of things extra, not only in doing an operation, learning, teaching book. That I have said already, simulation training is included, and finally the second day includes in small groups hands-on assistance. Of course, they must be on the OR and assist, and the focus is on the diversity of the hernia procedures. A get-together event is very important to get an of course, a good communication between all the participants. The third day, and that's not only on evidence-based, medicine-focused, we want to create a discussion about failure culture, about diagnostics, about the groin pain, and the right indication for hernia surgery. And then, of course, pitfalls is one section which is included. So I think that seems to be more attractive for younger surgeons. The second course is right now starting in Germany, the Hernia Concrete, which is a 1.5-day course with hands-on assistance in very small groups for all the advanced surgeons or basic course finishers. We have 4 standardized 1.5-day courses implemented in 20 selected training centers. The course modules are in the next slide, and we have an option to have an additional hiatal hernia course. Extra, you have the e-learning component, and they have an access to a huge video library. Training centers are for the open inguinal, endoscopic inguinal, open ventral, and endoscopic ventral hernias. And of course, all the different techniques will be shown so that they get an overview of what's going on. The selection criteria for be a training center are, of course, established, and there's an agreement that they should have 300 cases per year, They must make a quality management control by the database. They must have an experience in training and teaching. They must be a member of the German Hernia Society. And finally, the trainer education. It's something which is ongoing. The third course is a complex hernia course, which is not yet established, but that's the plan for this year, end of the year. We want to focus on more complex cases and might be also a discussion on a tailored concept, because in some cases it's not even that easy, like in the last presentation. The hands-on training is only in very small groups with 2 participants per training. And right now I would like to demonstrate that we evaluate every part of these courses. Of course, they appreciate this, but I think, is there a chance that you improve your knowledge and it could help in your daily practice? The organization will be proved, the scientific managers, the program is proved. Would you recommend this course to others is a question, and the training centers are in the same way evaluated. And if you can see in this slide, there are 2 exceptions, and we don't invite them a second time. So there is a pressure to have a good performance for all the attenders. The lectures will be evaluated also by the participants in every part, so we guarantee that we get the best of it. We can compare all the questions in a long timeline for all the courses, because we ask every time the same questions. And also, normally, most of the participants believe that you can improve the surgical education and the surgical or technical possibilities. That slide we have seen also. I think we prove what's going on before and after the course. And finally, I will conclude. We got an extremely positive feedback of these basic courses. There is not even an evidence on it, but we would like to develop such a step-by-step training. There is a feasibility of such a standardized training program with a continuous evaluation for the improvement, because we are the whole time in a learning process. Maybe the European Hernia Society has a chance to bring all the different teaching methods together so that we have a networking and an exchange of experience to make it a bit similar. And I can announce once again 2 courses. One in Austria is in November this year, and the next one in Hamburg. Who want to participate, you are, of course, very invited to this. The Hernia Days are simultaneously translated into English. There's no problem for any foreigner. And we have a lot of different international guests in our meeting. And of course, there is, once again, a study meeting, the second study meeting of the Hernia database, to implement also all the, I think, new informations of our Hernia database. Thank you very much.
It's very interesting. Questions? Do you have any feel, Ralph, as to the type of trainee that turns up? Is it the trainee that's already performing well, who wishes to come to your course, or is it trainees that think, I'm not doing very well, I need to go in the course? Because you have a lot of surgeons in Germany, you don't have a high volume of these courses as yet, so only a minority are going to get onto a course.
I think we have them both. I think, of course, we want to address this offer to everybody. So for that reason, we open it not only for residents and young surgeons, we want to open it to everybody. So that makes sense, because so you have a chance to improve something. I believe, of course, might be the most of them are a bit more interested in doing hernia surgery. I think we have in our country, that might be a bit different to UK, a lot of huge hernia centers. In the bigger cities, we have centers, they have an amount of, I think, 500 to 1,000 hernia operations per year they are doing. And might be that's a difference. I don't know the exact number. We have made the survey, and I don't keep the numbers into my presentation, but we have around 60 centers with an amount of more than 500 hernia cases per year. And that's a huge amount. And I think that's only the surface. We don't know exactly the number, but of course in huge university hospitals, I think the hernia is not even that common procedure. That's my personal belief.
David, do you have a question?
It's very good, but it sounds expensive. How's it funded?
The course, I think the most expensive course part is the anatomy with cadaver operations. And that's why we have made a funding with different companies. And of course, to keep them equal in equal parts so that there is not any company stronger than the other ones. So we make them equal, and normally it's necessary that you have 6 or 7 or 8 companies which are involved into this course, but only for the day of the anatomy. And then, of course, they have a chance to present their products in the lab.
And do the candidates on the course pay anything towards it?
The participants have to pay, but of course, to keep the payment low, I think it's there is a sponsorship by the German Hernia Society. All the participants of these courses get a free access of hernia for 1 year and a membership of the German Hernia Society for free for 1 year as well. So, of course, we want to attract them, and of course, we want to keep them in our community. And it seems to be, it works, because the numbers of members of the German Hernia Society has doubled in the last 4 years.
Obviously, that's a fascinating talk. And for those in the audience, should we follow Germany's way in terms of formalizing hernia education? So those in favor of following hernia, raise their hands. So a really strong show of support of trying to formalize hernia education. Obviously, there's still a lot of practical side in getting the numbers, but formalizing base knowledge and then follow-up seems to be important. One more question, was there?
Of course, normally you can't measure it in 1 year also. I think we just right now prepare a questionnaire to all the participants who have joined our course in the last 5 years or 6 years to get a feedback from them. Do they have made a change in their daily practice? And so we just prepare this, but I couldn't present the results on this. But of course, we have all the, I think there are right now 400 participants in Germany. It's not even much, but I think that's a beginning. Might be it's getting a bit more attractive, and of course it's a long period of time, and normally the long-lasting effect, we don't know it exactly. I couldn't say anything about this. Thank you very much. Thank you.
Now our final speaker, current president of the British Hernia Society, is going to chat to us about another topical subject of PROMs. And while Martin's coming to the podium, if I could just put a little plug about the British Hernia Society. As from this year, membership of the British Hernia Society is free. You just need a GMC number or a registered nurse practitioner number, and you can become a member of the British Hernia Society. And one of the reasons for making it free is that we don't have a lot to offer, but we want to engage the wider community, both surgeons who do a lot of hernias and consider themselves specialists, and those who do very few and wish to keep in touch with us. So a plug to join the British Hernia Society for those who haven't. If you Google British Hernia Society, not BHS, you'll end up in some dodgy department store that's struggling, the British Hernia Society, log on to the web, register, you'll be sent your passwords, and please join the British Hernia Society because it's free to join. And sooner or later, we will reward you for joining. Thank you. Mark.
Well said, Andrew. I was going to ask the same question. Should we have a show of hands? Who are members of the British Hernia Society? Excellent. Good. Well, you can all join this evening. Thank you very much for staying to the end of the session. We'll try and make it worth your while. I wanted a provocative title. I don't know if a question mark makes it provocative enough. I did think about saying not fit for purpose, but I plumped for the middle road, thought I'd be a bit conservative. How many of you think that the PROMs data or the PROMs that we're using for hernia are fit for purpose at the moment? I'm going to ask you how many think it is, how many think it isn't, and how many don't know. Should we have, how many think it's fit for purpose? No one. Wow. Not fit for purpose? And what about don't know? Okay, well, I don't really have an agenda. I actually don't have an agenda, and I must say, over the course of this afternoon, I have oscillated a bit, backwards and forwards, wondering what is and what isn't the right answer. Let's try and interest you and educate you. Well, just a little bit of background. As you know, this was introduced by the Department of Health, became mandatory in 2009. I think they actually proposed 5 procedures originally, and if you read some of the literature recently, they've had big problems with cataracts, because just to mention it now, to get it out of the way, they've shown that people who've had cataract surgery have a diminished quality of life, and they don't quite understand what's going on with that database. But I'll leave that for the time being. There's quite a lot on the internet about it. This is the website that's currently up, explaining to patients about PROMs. And as you know, every few months, this comes out on the HSCIC website, and you can look at the PROMs data for those 4 procedures, which are hips, hip prosthesis, knee prosthesis, varicose veins, and hernias. And I think these statements are quite alarming in the sense they're going to be used as performance indicators for the various procedures. NHS commissioners are going to use the data, and they're going to be used to compare hospitals' performance. And you do really want good data. And as David mentioned, and as you all know, there is not a condition-specific PROMs for hernia, although there is for knee, hip, and varicose veins. This is a worthwhile article on the internet, published in 2010 by Nancy Devlin, who was very involved with the analysis of the PROMs data. And some of the blurb from the front page is on the right-hand side, and I've picked up the important phrases from that front page. And I think that's worrying if they're going to use generic data to analyze the results of hernias. They're going to use it to measure and manage the performance of hospitals, going to allow patients to choose a provider, look at the productivity of the NHS in terms of hernia repair, and look at value for money, resource allocation, and that kind of thing. So you do need a good measure of quality of data. PROMs data obviously has to demonstrate the value of an intervention. How does the intervention change something for the patient? And you have to do something that's condition specific. You can't just ask a generic quality of life question. And the important thing about PROMs is that it's patient reported. It's not what we think they should be reporting on. It's actually what concerns the patient. You go to a hernia patient, what's worrying you? Why are you having this operation? And then you can ask them afterwards, did we address the problem for you? Generic and condition-specific PROMs. This is the part of the generic PROMs that they're using for hernia. It's the EQ-VAS, EQ, the Euroqual system, which was just a collection of scientists, as far as I can work out, who got together to try and work out issues of quality of life. Almost all of my patients coming for hernia repair mark 75, 80 or above. I've had one patient in the last year and a half while I've been using this who's marked 30. And that means that I get what's called a ceiling effect. It means my pre-op patients are so near the top of this line that no matter how good they might feel on a sunny day 6 months later after my hernia repair, they're not going to appear much better just because of the hernia repair. That's a ceiling effect, and that's a problem with this EQ-VAS scale, which actually is about 40 years old. And similarly, for the equal 5, this is an equal 5-3, which uses a Likert scale with 3 questions. Some of them have 5. And as David mentioned earlier in the day, these aren't particularly relevant to a hernia question, to a hernia patient. All of my patients can wash themselves and dress themselves. None of them are confined to bed. Most of them can perform usual activities. If they tick any box at all below the top one, it's this one. If they can't play tennis, can't get around the golf course, can't sit at a desk for a long time. Some of them have moderate pain or discomfort, but none of them have extreme pain or discomfort. And the anxiety and depression really are not usually related to the hernia. So this is another part of the generic questionnaire that's unhelpful in looking at post-op data for hernias. Operated on this chap yesterday. I'm going to anonymize the form so you don't see his name, but as you can see, he's ticked all these boxes, marked his health state today as 90. I'm just not going to improve on that with my hernia repair. Earlier on in the day and over the last few weeks, I've said to myself, well, should I be operating on these patients at all? And I was in slightly two minds at the beginning of the day. Paddy O'Dwyer has convinced me that I should do. He came very convincingly down on the side of operating on relatively minimally symptomatic hernia, saying they will give a problem, but that's a problem that we all need to address. This is a sample of stuff that I took off the database I've been collecting over the last year. And as you can see, these top 2 patients had a health scale score low, 60 on the EQ-VAS before operation, nice and high afterwards. They would have come out well on my questionnaire. But look at these chaps who couldn't remember what they wrote 6 months earlier. They probably felt good afterwards. That indicates they did feel good after my operation. But this would be recorded as a fall in quality of life with this not particularly good design of questionnaire. And that's been questioned in this recent article from 2014, I think it was. And it questioned whether the EQ5D is an appropriate measure. And I put it to you that I don't think it's an appropriate measure to base the decision on whether or not a hernia repair is effective on. This is what the data looks like on the PROMs site that you can look up. And as you can, and this is the stuff that John Appleby, I'll show his slide on the next slide, and David showed it earlier on. And as you can see, the hip and the knee scores with their specific questionnaires have shown improvements of 96, 94%. Their EQ-VAS, about 50%. Hernia doesn't do as well on the generics. And of course, there isn't a specific scorer for it. David's spoken about this. John Appleby tweeted this. A couple of comments afterwards. Queried the EQ5D. Wondered whether we should be spending money on hernia repair. And of course, if this goes through and is used by the commissioning guidance people and the health authorities, they are going to stop hernias being done by the NHS. So it is in our interest to present some good, specific data. David alluded to the various trusts that are not repairing hernias unless there's a major problem with a patient. Let's look at some of the ways we can develop a condition-specific PROMs for hernia. You do have to validate your questions. They're not immediately obvious, and in fact, I'm trying to do that with some of my patients now. Get a questionnaire together, look at what's really important to patients. Previous questionnaires, there are quite a lot of them, have always looked at pain, and I think there's more to a hernia than just pain. The one that I like the best and that I've chosen, and I'll talk briefly about now, was derived from a low back pain questionnaire altered by Sterkel from Switzerland, modified to include a hernia questionnaire. This is Todd Hannaford's Carolina Comfort Scale, which I think takes too long to fill in. This was the paper from Sterkel, and this is the questionnaire that he proposed, and I've been using for about 18 months. Asked about problems, pain or discomfort in the past week, testicular pain, whether patients have had to take any painkillers, numbness on that side, and then some very specific questions, quality of life questions, and I give them a free text box as well. And this takes them 3 or 4 minutes to fill in, and I give it to them at the time of the consent form, leave it in the room, collect them. You've seen some of the data that we've got. I don't think this questionnaire answers that little box there. I don't think it particularly asks all the questions that might be of concern to a hernia patient, and I'm thinking of some different questions without making the questionnaire longer, and I don't know if you need all of these questions in, and I think that's something that I'd like to get up on the British Hernia Society website, open it out as a forum to surgeons with an interest in hernia repair, what kind of questions we should have on a questionnaire for pre-op hernia patients without making it too long and clumsy. I looked at my data over the last 12 months, my EQ5 data, deterioration 20%, but when I looked at my hernia-specific questionnaire, the improvement was almost 90%, still some deterioration, but results looking like the hip and the knee scores using a hernia-specific questionnaire. I mean, that's just a comparison of the two to remind you. That's my patient who had marked almost everything satisfactory. Getting the correct questionnaire together is only part of the problem. This recent paper looked at all the problems that we have in collecting, and it's less of a problem for me because I just have a relatively small number of patients and I collect the data myself. But I think there have been a number of articles in the recent literature looking at the problems the NHS is having collecting this data and coding it correctly. And a lot of my patients incorrectly mark the form, and I can correct it with them when I look at it, but if you're just collecting forms in the NHS and passing it on to a coder, they do have problems with patients who have incorrectly marked the form. So that's a problem that you're going to have in the NHS. Nick Black has written a lot and is very involved with PROMs. I think this is a true statement, but it may do it in a way that we don't want. I think if we don't develop a hernia-specific questionnaire for PROMs, we're going to have a major problem fighting a system that is trying to say that there's no benefit to repairing a hernia. as Andrew said, look forward to seeing you all in Newcastle at the end of the year. And I know you're all going to join the British Hernia Society. Thank you.
A couple of minutes before we join the rush for the alcohol. Any questions? It's a pretty good overview, Martin, as to where we're going, but we clearly have a long way to go.
It's sad that we don't have a generic questionnaire for hernia. I can't believe that we, as a group of general surgeons with an interest of hernia, have not developed something relatively straightforward. It's not a complex condition, and I think we should address it now. Start asking our patients, why are you having a hernia repair? I must say that listening to Paddy earlier on and having thought about this over the last week, you do have a problem with an asymptomatic patient with a hernia, with an obvious swelling. If he then develops pain afterwards and he says, I regret having it done, and you do need good data to show that he would have run into problems. Paddy has convinced me that patients would run into problems, but it's not so easy to prove. I think that's going to be our challenge. I think that's it, yeah. We're all adjourning to the...
Thanks very much, Martin. Thanks for coming. All the very best. Enjoy the rest of the conference. Safe trip home.